We will go ahead and get started. So welcome to the first grand rounds of 2018, a new year, a new me. So we're looking forward to a good year for grand rounds. If there's any topics or anything else that you guys want me to look for speakers for, maybe a refresher on certain topics that you haven't heard in a while, please let me know so we can try to get that programming for you. So today we will be doing a case presentation, and as per usual for these case conferences, please feel free to participate, and otherwise I will actively pick people such as Geet, who rarely makes an appearance here these days. So she's gonna. Okay. All right. We don't get to see it. We don't. Okay, so this case is a case of a 24-year-old female who unfortunately had a diagnosis of breast cancer, which was ER/PR positive. She had discovered it when she discovered a lump in her left breast, but she underwent a mastectomy and adjuvant chemoradiation with adriamycin and Cytoxan and Taxol afterwards. It was doing quite well as far as remission and had been followed regularly by oncology without any issues. Who presented with 1 week of fevers and tender cervical lymph nodes in her neck. She reported that about 2 weeks ago, she had seen an urgent care doctor for some right ear complaints and had been diagnosed with a right ear infection, had been given some antibiotics for it. But she had finished the course, she had received Ceftonir for about 7 days, and she had finished that course 7 days prior to her admission. So she'd been on antibiotics for quite some time at that point. So she was seen in routine oncology follow-up just for her breast cancer as a routine visit. But at that time, she was still complaining of neck pain, and at the visit was noted to be acutely febrile. So she was noted to be, that's actually 38.4 in clinic. So she's noted to be 38.4 Celsius in clinic. Labs that they drew at that time showed that she had a white count of white 1.8 with an ANC of 700. So based on everything going on with her, they sent her immediately over to the emergency room for evaluation. When was her last? We'll get to that, but her last chemotherapy this case was last year, 2017. So her chemotherapy was August of 2016, so about a year prior. So it had been some time before she had received systemic chemotherapy. She was on hormonal maintenance therapy for the ER/PR positive breast cancer, which was anastrozole and leuprongitans monthly, but that was really about it as far as her medications. And as I mentioned previously, she had just completed the course of the cephalosporin orally, but that had been about a week prior to her presentation. Other history, she had a penicillin allergy, but had tolerated cephalosporin, and her family history and social history were non-contributory. So at this point, we'll take a moment to pause and ask the audience, what else do you guys want to know about this patient prior to getting to her exam findings and that sort of thing? So she reported no recent travel. She was originally from Antigua, but had been here in the States for several years, but no recent travel outside of the New York metro area. She was from Long Island, I believe. The last labs were probably a few months ago prior to admission, but they were all normal limits. So she was never known to have any leukopenia prior to this. So she had complained of the lymph nodes in her neck, so she said it was very tender in her neck, but she had not noticed any other lumps anywhere else in her body.
Was she having any respiratory symptoms?
No real URI symptoms. She sort of had some of that right ear pain 2 or 3 weeks ago prior to admission, but otherwise nothing too significant as far as URI symptoms. No shortness of breath.
Ever been TB tested or quantiferin tested?
She had a quantiferin 2 years ago as part of her chemotherapy, but had been negative from that. And no known TB exposure. Swallowing was fine. No issues there.
HIV scans?
Never tested. Not recently tested.
Meds that weren't not those prescribed meds, like herbals?
Yeah, so no other reported herbal supplements, that sort of thing.
Rash?
No rashes.
Did you mention weight loss?
I did not mention weight loss, but she did not complain of any weight loss. Yeah. Okay, so it sounds like you guys are all sort of trying to gather history as far as, other etiologies for the lymph nodes. She has some dogs at home. Any particular pets you'd be concerned about at home? Okay.
Cats.
Yeah, so we can see for cat scratch disease, you can see with kittens, so she did not have any cats at home, reportedly. So good, so nice thorough history. Good job, guys. So as far as her physical exam, she was noted to be acutely febrile in the emergency room. Her temperature was 38.7. She was tachycardic. BP was okay, and she was sounding well over there. As far as her physical exam findings, aside from the fever, she was not in any acute distress. She was noted to have bilateral cervical lymphadenopathy, about 1 centimeter, firm, not matted, and mobile. But otherwise, she didn't have any other significant lymphadenopathy anywhere else in her body, so none of the other sort of culprit areas that we look at for our lymph node exam. I forgot to mention she did have a port for she'd been on chemotherapy, but she still had the port for whatever reason. So, but that site looked okay. Okay, so this is her initial laboratory. So pretty unremarkable for the most part. Her BNP was within normal limits. Her chest X-ray was normal. Her urinalysis was normal. The only thing really significant was she had some mild elevation in her LFTs up to the 60s, and she did, of course, have the noted neutropenia. The rest of the dip was normal. So that's her laboratory. So getting to our differential. So you guys sort of alluded to.
On her exam, did she have anything come out?
As far as like ulcerations, or what are you referring to?
Like erythema, tonsills.
Yeah, nothing as far as anything else in her head neck exam. Yeah, just notable for the cervical lymph nodes. So you guys sort of alluded to things that in your history, as far as things that you were considering your differential. Does anybody want to take me through their thought process? Geet? Just kidding. I won't pick on Geet. Unless she wants to volunteer.
I think it also depends on when you say your problems. There's like, so if you say it for one-liner,
Okay.
and say like what your differential. Say there's multiple things you can have a differential for.
Okay. Well, so what would you be most concerned about right now?
This is like a 24-year-old woman, history of breast cancer, thought remission, presenting with like fever, tender lymphadenopathy, and like
Right. Okay. Yeah, definitely. So that was something we were concerned about, the new neutropenia with the fevers as well. Although not necessarily chemotherapy related, still something that was concerning for her.
Be concerned initially about kind of this is something like acutely patient's fever, leukemia, and lymphadenopathy. Think about all the viral infection that causes HIV. It doesn't have any localizing thing that's local that you are on, or flu, or CMV or EBV, when you say them without. Also, for the size of the lymph nodes are more large than you expect, and you find the kind of syndrome. In that case, you think about any kind of malignancies like lymphomas or sort of, especially since just although it's not been long. It's still young.
Yeah. So yeah, that was sort of our thought process exactly, Missy. So thank you for that. So that was kind of what we're most likely thinking. Given the short time frame, we were thinking this is more of an infectious process. But she was sort of a unique case in that she had a history of breast cancer and had undergone chemotherapy, not anytime recently, but still at risk for sort of those malignancy-related issues.
But I think you also like want to think about what's your differential for the neutropenia. Because like, is it in the setting of sepsis? Is it something that's med-related? Is there like does she have like a different like bone marrow issue?
All right, so yeah, so whether the neutropenia is tied in with this lymphadenopathy, whether they're separate findings, and that was also a little bit unclear when she first came in. At this point, so what other studies would you guys want to obtain? Either laboratory or imaging-wise, or nothing at all? CT, so you jump straight to a CT, Harry? Okay, and what would be your thought process behind that?
I mean, if you got bilateral, it's tender. You got fever. So you want to see where it is and if it needs drainage or if it's a biopsy.
Okay, yeah, so whether or not it's suppurative or not.
So next CT.
Yeah. So you would jump to that kind of right off the bat admission? Okay. But anybody else want to wait and sort of see what happens, or?
Well, I think she did blood cultures, because you're gonna start on antibiotics. Though technically she's been on september. If she's been on that, then she's
Right. No.
Just start with this fourth protocol.
No, nothing that she.
Chest X-ray.
Right. Yeah, the chest X-ray was normal.
Okay.
So
Monospot, maybe.
okay, yeah. So some viral studies. So those were sent initially as well. So Rita, when I asked the question about whether you would want to image her right off the bat, you were shaking your head no. Do you want
I
to?
think I would get EBV titers, blood cultures, like all the infectious workup first, because she's tender. I mean, it could still be a malignancy, but where she is neutropenic. But I think I would wait to image her until some of the labs are back.
Okay, so that's kind of a fair approach as well.
Yes.
Peripheral smear. Okay, that's never a wrong answer. Anybody else want to weigh in on the great debate about whether to image right off the bat or not? Or what would you do? I guess we'll frame it that way.
In part depends on your exam. Like how tender is she?
Mhm.
How did you see anything that's potentially functioning? Because if she's neutropenic, people are going to want to start on antibiotics first and wait before treating it unless her airways are fixed.
She's tender and not fluctuating.
She's not functioning.
Not fluctuate. Yeah.
Still.
And then how big were her lymph nodes?
Like they would say, like maybe like up to a centimeter.
Okay, so you're not. I mean, it doesn't sound like we're worried about like dysphagia or airway compromise.
No,
or
yeah,
anything like that
yeah.
because of the size, so.
Okay. So let's see. Infectious studies and viral studies, and the usual sort of culture stuff for bacteria. And we talked a little bit about how we would initially manage these patients. So here's what happened with her to start out with. So she was started on cefepime for the neutropenic fevers. She still remained intermittently febrile even despite being on antibiotics for the first hospital day or two. Pretty high fevers. They were up to like, I think they were up to like 39 at one point, so pretty significantly febrile. But she herself, other than the fevers, was feeling pretty okay. Didn't really have much complaints other than the neck pain. Let's say it's hospital day 3 now. So at this point, she's still intermittently febrile and still with the neck pain, and her ANC has not changed. Still under 1,000.
All the viral titers.
Those are still pending. Those are still. well, you know how it is. You just sent them. They're not going to come back on hospital. Blood cultures have remained negative, so nothing so far. Culture data has been unremarkable.
So what did the What's the white count doing?
The white count is hovering in like the one point somethings, and the ANC is not. It's been basically hovering between like 500 and 700. So really, it's really kind of fluctuating up and down.
How's the CBC and the LFTs?
The LFTs, I don't remember off the top of my head, but let's just say that they were not significant. They were similar. And
I mean, for me, the next test would be CT, chest, abdomen, pelvis, to see if there's any lymphadenopathies or organomegaly going on.
okay,
So I would have preferred to get the viral studies first.
okay.
But if you couldn't, then I'd be.
Okay, we'll say the CMV came back negative. The EBV came back IgG positive. So, Dr. Dunn, would you have been one to image her right off the bat as far as the neck, or would you have waited?
I probably would have waited for some of the simple viral titers.
Okay. Okay. So let's see what. So let's see. So we waited till hospital day 4. At that point, she was still febrile, as I mentioned, and at this point, she was complaining of a little bit more right neck pain, and she was still neutropenic. So that was when we decided to get the CT of her neck, because at that point we were sort of doing the same thing. We were watching and waiting, trying to see if any of our laboratory had come back to point us in one direction or another. But with her having more complaints, as Harry mentioned, we were concerned that maybe this was more of a suppurative lymphadenitis. So at that point, we decided to get a CT neck, and that did show some bilateral cervical lymphadenopathy. And as far as the part that they could catch of the axilla, she did actually have bilateral axillary lymphadenopathy as well. So, does that raise any eyebrows, or? Not good.
How big were they?
Up to 1.5 centimeters. Yeah. So this was new. Yeah. So at this point, is this changing anybody's thought process at all, or kind of any leading diagnoses at this point?
When the systemic infections or systemic malignancies, you're thinking, HIV, SBE, things of that nature.
Okay.
You're still thinking cancers, you're still thinking infectious, this kind of
Okay.
And this could also be like a weird autoimmune things for like cancer, just crazy things like that.
Yeah, definitely. Okay.
I went there.
Okay. So we have the. This is my favorite. This is one of my favorite emojis, by the way. Useful in most any situation. So we talked a little bit about now what would you do, and so any thoughts as far as what you? So Dr. Dunn said he would want to image the rest of her body. I see a lot of nods, yes. So we actually, oops, we did. I was jumping a little bit ahead. We actually did image the rest of. We did image the rest of her chest, abdomen, pelvis before we jumped to the biopsy, and it was actually unremarkable. So just the axillary lymphadenopathy, but nothing as far as like abdominal. It was normal. So just she had the axillary and she had the cervical, but nothing as far as like abdominal, pelvic, inguinal, that sort of thing.
Does she have Bartonella titers then?
Yes, they're still pending.
Oh.
They take a while to come back.
Ehrlichiosis and all of this kind of stuff is sent to.
We didn't send her ehrlichiosis. We didn't really have a high suspicion for it.
Hiking in the woods.
Yeah, she didn't. What's that? What were you saying? Video? Oh, okay. Okay, so oops, I kind of jumped ahead. So we had the CAT scan, and let's say it's now hospital day 7. So when would you guys start to think about doing something differently? Assuming
So she's still febrile?
she's still been febrile. She's been triggering sepsis BPAs every day. RT has been coming.
7 days. I assume after, like, if she's still febrile after the sepsis, she's probably brought us antibiotics.
Right. So that's one question I wanted to ask. So as far as her antibiotics, so she's still neutropenic, and she's been on cephalin this whole time. So how would you guys manage her antibiotics? So Sophia, you're saying you would just do a 7-day course?
So I would have brought in her to like gram-positive even before, and then I think is it called 5 days for the IDSA guidelines? If it's 5 to 7 days,
Yeah,
and we have not found the source with imaging, then they recommend adding antifungal.
Yeah, so that's around day 7. Is, yeah.
She did get a chest CT. Sorry.
So she did get a chest CT. It was besides the lymphadenopathy, it was unremarkable.
So she's just on cephalin right now.
She's just been on cephalin for day 1 to
7 already. 7 days.
day 7 of it.
Culture's been negative.
Culture's been negative. All the infectious stuff that's been trickling in. You would stop it? Okay. Would anybody consult ID for second opinion, or just? Oh, when we,
I was like, I already did. I just didn't
when,
say it.
okay, Tal, when would you have consulted ID in this case?
I mean, by now, definitely would have, but I think if you're, like, if you continues to be neutropenic, then even before, I mean, when you image and you don't find anything, you try to call IT.
Just like you already did the biopsy.
Well, we haven't gotten there yet. we're at let's say we're at like hospital days 6, 7, or maybe we can talk about. Well, anybody else want to weigh in on the antibiotic situation, or
In
with most?
some ways, it depends on why you think that she's neutropenic. Like, if you, I didn't say I was in a setting like chemotherapy, for the most part, like where people who have like benign neutropenia, that's not something you want to share. I think she's the same now, hemodynamically, that she's been since before she went into this program.
True. Yes.
So,
If your thought process is that this is not infectious right now, like bacterial infection,
Mm-hmm.
like that doesn't matter if you can stop antibiotics, but if you doesn't sound like this doesn't seem to be bacterial infection to stop it. And normally this was a bacterial infection to increase, so the ENC to increase. After that, before you stop antibiotics.
Okay. And
I kind of agree with everyone. I mean, she's fairly stable. Just her neck pain is getting worse. It means that it's not keeping. So if there wasn't a section, then someone that, we did talk about Bartonella and sort of fit that differential, but that's the only thing you wouldn't keep covering. And there's like CBD and that. So I wouldn't change much except maybe stop it.
Okay. Who, by raise of, so who would at least have consular ID in this case? Okay, everybody. Sort of, what would be your threshold to have consulted them? So I think some people mentioned once the imaging came back, sort of unremarkable. Anybody have any other different thresholds to share?
Before going for the biopsy, because right now you have sent all the infectious workup with nothing malignancy. You want to get IV involved to see if there's any infectious thing that would cause kind of lymphopathy that you're not thinking of.
Okay.
Before you go ahead and do the biopsy.
Yeah. So yeah, I think that's a great threshold. You know, just getting a second opinion before you do an invasive procedure.
Was the smear okay?
Smear was fine. Okay. Let's see. This was in June. Why August?
Summer.
Oh,
Summer.
tick-borne disease. Yeah, so nothing. Yeah, I think Andy mentioned that earlier, but no tick-borne exposures. Let's see. There were dogs. She was around dogs. So going to the next question. So she's still febrile, still neutropenic. So what would sort of be your threshold to jump towards a biopsy? Or,
I mean, I think at this point it's reasonable. You really don't have much. Yeah. There's bone marrow biopsy and there's lymph biopsy because lymph node is accessible.
okay. Yeah. So finally, on hospital day 8 was when we decided to go ahead and get the biopsy, and he had been followed. What's that?
You took your time.
Oh, so you guys are a little bit more aggressive, I guess. Well, since our luck day is up, this is a good point to segue into who would have pursued a biopsy sooner.
I guess if the CT of the body was done on day 5 and was negative, the patient's still febrile, like around then I think you have to start thinking about tissue.
Yeah.
So soon after the body imaging was negative, you really don't have that.
Yeah, I don't remember the exact time. I think maybe it was just a logistical thing where we had to wait till hospital day 8 to get the biopsy. I think it was a Friday, I want to say. So she did finally undergo an excisional biopsy. Hematology had been following all along, and they didn't really have much to comment on as far as the etiology. They were concerned about a lymphoma or a leukemia type picture, so they did also want to get a concurrent bone marrow biopsy. And she'd had a flow sent like a few days prior, which was pending.
Did they tell you to stop her
They did not. No. Yeah, so we can see that, but I think she was still on it. I want to say, and she was still kind of fevering all along, triggering RT and driving the residents crazy with the sepsis PPAs. So we finally discontinued antibiotics at hospital day 10. It took a while for us to do that. I think ID had been following, and then I think I'm not exactly sure why we extended it for so long, but finally I think it was just due to the weekend, and I think we just decided to keep it on for the weekend. But the bone marrow biopsy returned normal, and so hematology felt comfortable giving her a dose of Neupogen, since there wasn't any concern for malignancy, at least in the bone marrow. And she responded quite nicely to that with a white count improvement, and her ANC recovered. And she had actually stopped. She had defervesced since hospital day number 9. I think that's probably why we were waiting still for the continue antibiotics for a little bit longer.
Did Ivy think that this could have been viral?
They sort of posited that they didn't really think it was infectious whatsoever, to be honest.
Oh,
So that's sort of why they cut the brakes on the antibiotics.
Question, maybe, can bone marrows look normal if you're neutropenic? Like, wouldn't it show a paucity of something?
I'm not sure for like neutropenia in itself, but I think yeah.
I don't actually know. Like when you're anemic, they show like a paucity of red blood cells.
Right.
Is that true?
Whether or not there's like the white blood cell precursors. Yeah, it was reported as normal, so whatever normal means in this situation.
Did her spleen look completely normal?
The spleen, yeah, there was no splenomegaly on her exam, or on her exam and on the CT.
The building is having a fever. So we're looking at who would leave. I get an ID puzzle first.
Well,
These are old velvet.
Can you tell us what's going on?
Yeah, what?
Okay, all right.
Is it real or not?
I don't know, should we leave?
I guess we'll find out soon.
Okay, so the lymph node biopsy returned as necrotizing lymphadenitis, not finger hands, so with common histiocytes. Yeah. So the histologic differential included Kikuchi disease, lupus, or cat scratch disease. What's the first one? That's a good question. So we'll talk about it in the next, but this is a sample slide of what the histiocytes look like with necrosis.
What? It stopped.
Okay.
Phew. Okay.
Fire has consumed the alarm.
For installation of the entire department hospital.
Put a couple of chairs and bookcases in front of the doors in case it.
Yeah, so that was basically the pathologic differential based on this. But I had never heard of, well, maybe back in medical school, I briefly remember learning about it, but Kikuchi had never passed my radar, so we did our quick up-to-date and up-to-date Google search, and it did fit her characteristics, which I will talk about in just a little bit. So we diagnosed her with Kikuchi disease. That was not in the differential. She did not have TB. So what is Kikuchi disease? Besides being a fun name to pronounce, it's a disease that was first described in 1972 in Japan by two different groups, actually, by Masahiro Kikuchi and Fujimoto. Unfortunately, Kikuchi purported it first, so he gets most of the credit for it, although some people, in fairness, they hyphenate it and say Kikuchi Fujimoto disease. So it's a rare but benign etiology of lymphadenitis, typically affecting younger women, so usually the age ranges in the 20s or 30s. It can affect men, and it's been mostly described in Asian ethnicities, but it has been seen in basically all ethnicities now. It's been reported in all ethnicities. Our patient in particular, she was African Caribbean, so certainly, can affect any ethnicity. As with most of these sorts of things, the pathophysiology is not quite clear, but there is some question about whether it's a T-cell mediated response to a virus or some sort of other infectious etiology. So the clinical manifestations are quite varied, and that can make it confusing for other diseases like we've talked about throughout this whole nice discussion. But the predominant features are fevers, which our patient had, of course, and then also localized lymphadenopathy, usually within the cervical chains, which of course this patient did have as well. Other presentations can include other sort of nonspecific symptoms, such as nausea, vomiting, myalgias, arthralgias, night sweats, weight loss, diarrhea, rash, and so all these sorts of things can obviously be very confusing for other things such as lymphoma, autoimmune diseases, and so forth. So certainly something that can be very confusing. As far as laboratory findings, you can see leukopenia, which was seen in our patient, and also you can also see pancytopenias as well. The LFT abnormalities are not typically described in Kikuchi, so I'm not sure. I don't know if we ever had an explanation for that. I have to go back and look. So definitive diagnosis is by lymph node, as we did in this case, and unfortunately, it's not a slam dunk once you actually get the lymph node biopsy, because as I mentioned before, the histologic differential includes lupus, which can have very similar features with all the arthralgias, etc. Cat scratch disease, again, she did not have exposure to any cats at home. And before any sort of molecular staining, just grossly, it can look like lymphoma. And there have been cases reported in the past of pathologists who are not familiar with this diagnosis actually diagnosing these patients with lymphoma. And these patients have gotten chemotherapy by mistake. So certainly it was very nice that our pathology department is very experienced and was able to give us a good differential for this case. So fortunately, for the most part, these patients do well. Really, the treatment is just supportive care, but they usually resolve within weeks to months on their own without any further intervention. There have been reports of using steroids and that sort of thing, But there really, obviously, for something so rare, there hasn't really been any randomized trials to really compare what the best treatment is. But most patients have, in case series reports, have done well with just observation.
And do you know when is sort of like the usual time it subsides?
Anywhere, the reports I read said anywhere from like 6 weeks to like 3-4 months. So kind of a medium range duration, I guess. Fortunately, she defervesced within like a week or two. But I guess if you go back to when she first presented, she sort of had these like, she presented with the right neck pain initially to that urgent care, which was like 2 weeks prior to admission. So by the time all was said and done, she'd been maybe 4 weeks with symptoms.
And axillary lymphadenopathy.
So it can be seen also with Kikuchi's as well.
Did she stay in the hospital for over 6 months, or did you have to start before?
Yeah, I knew she was in that DRG where I wouldn't want her to. I wanted to wait until she became an outlier, so she was here for like 3 months. And then Pierre discharged her? No, I'm just kidding. There has been some association with lupus. There really isn't a strong connection. The actual percentage is not really known, but the case reports that have looked at patients with Kikuchi disease have noted that some, very few patients have gone on to develop lupus as well. So whether that's like an early manifestation or not is kind of hard to tell. But lupus is something, and because it is on the differential for the pathology, it is something that you want to check as far as like ANA, dsDNAs, those sorts of things.
Any association with malignancy?
So no association with malignancy. Yeah, that's she. I think. Yeah, she was BRCA positive. Yeah, so I think that was her risk factor for that. But certainly not within her luck to get this really rare disease as well. But we were actually very happy that this was the etiology as opposed to like malignancy or lymphoma or something else, given everything else that she's been through already. And she was a very nice young lady. So just a quick review on lymph nodes, since that is something that we commonly see in the hospital setting. So, in our discussion, we sort of discussed, when you'd want to get a biopsy, and we sort of discussed our time frame for doing that, whether or not that was early or too late. But the overall prevalence of malignant lymphadenopathy is pretty low. In one study, they looked at it was only 1.1% of unexplained lymphadenopathy, meaning that based on history of physical, there was no alternate diagnosis. It was only 1.1% of those cases. Because we are a referral center, there have been studies looking at that and the incidence of malignancy, because obviously these patients are a little bit sicker or have some other features that are high risk and get referred. So it may be a little bit higher for patients who come to us through the emergency room or whatever else needs. Malignancy risk does increase with age. So she was in the age range where, taking aside her sort of chemotherapy and breast cancer history, she was in the age range where you would not really think of malignancy. It's up to 4% in patients greater than 40 in one study versus 0.4% in patients under 40. So again, they're older, we would certainly be more concerned for something more malignant, but younger, usually not so much. And those patients do okay with observation. I personally am not a big fan of mnemonics because I can never remember what the actual mnemonic stands for. But one mnemonic to use for lymphadenopathy is Miami, which includes things that we've already talked about already at length: malignancy, infection, autoimmune, miscellaneous, which Kikuchi fell into in the review article I was looking at. Kikuchi fell into this, as well as Castleman's, which David brought up earlier. And then iatrogenic, as far as medications, many medications can cause lymphadenopathy. Leah was alluding to checking for supplements and things like that can also surreptitiously cause lymphadenopathy. So just a quick review of the Miami mnemonic. So let's see. Castleman's disease, which I actually don't really remember much about. So, and histiocytosis, Kawasaki's disease. Something Cervidia might see, but maybe it's us we may not see as often. Kikuchi's, I think they just look at what Kumura disease is and sarcoid. But the whole host of viral stuff and also some bacterial stuff is also here. And we did send for most of these, and those were all negative or unremarkable. There's your scrofula, Herscher. So let's see. A quick review of just some the lymph nodes that we examine, that we do on our exam for. So again, she mostly had posterior cervical chain lymphadenopathy. She did not, interestingly, have supraclavicular lymphadenopathy, which should be more concerning for malignancy, as we learned in medical school. As far as evaluation of lymphadenopathy, we sort of went through most of this already, as far as taking a good history and physical, as you guys all did great today with our discussion, and just looking at the exam characteristics as far as the size, where it is on the body, how it feels, whether it's mobile, matted, etc. And then whatever ancillary testing for whatever you're suspicious for in your history and physical, and then determining. In an outpatient setting, these patients usually can be followed within 4 weeks. And if they still have persistent lymphadenopathy, then that's when you would consider biopsying. In the hospital setting, it's a little bit different because they may have different circumstances, such as our patient with her neutropenia and fevers. But for the most part, even for patients who have lymphoma, they're still within the window of treatment if you wait 4 weeks to observe and make sure that and see if it's persistent or not. So theoretically, we could have avoided the lymph node biopsy in the hospital and just sort of sent her home. Although that may have been a little bit uncomfortable with her still actively being febrile and neutropenic. So I think we were sort of obligated to complete a workup in the hospital, given her other risk factors such as the cancer and the chemotherapy history. So she was discharged home with routine oncology follow-up. She was seen by Dr. Fasano, and she had repeat imaging, which showed complete resolution of her lymphadenopathy. And she's been doing well. She still comes here for Lupron injections, and looks like she's still in remission from her breast cancer, which is great.
Is this recurrent? Sorry, did you
There have been some cases of recurrence, but the thought is that it's like maybe less than like 5% at most, if anything. So yeah, usually these patients self-resolve and it doesn't really come back. There's been like one or two there's always like one or two in these case series of Kikuchi disease. So just to summarize, some take-home points for this case. Lymph node evaluation requires a careful history and consideration of the patient's risk factors. Again, just doing a really good history and physical to determine the risk factors, as we all did that exercise earlier, which I thought was great. Most patients with lymph nodes can be observed. Again, in the hospital setting for us, this may be a little bit different depending on the circumstances, and we may actually need to have a biopsy. But if there is some incidental, these patients, we can safely have these patients follow up with their outpatient providers for observation. And finally, Kikuchi disease is a rare but mostly benign etiology of lymphadenitis that can present with fevers and leukopenia. So something to be thinking about next time you have a case of fevers and lymphadenopathy. So, any comments?
know we talk about like the computers do our job and like just work for me for a second. This wasn't on like anyone's differential. It seems like I wonder with like that sort of technology aided like that what's that computer that went on Jeopardy?
Watson?
Yeah, like if stuff like that, like it would have at least been raised to someone's attention. Like it's not on the up-to-date list. It's not on lots of lists.
Well, I think it actually was. I think it did end up being on the up-to-date list, and we were like, oh, there it is. But as far as your point, yeah. So as far as like human knowledge and that sort of thing, and so there's an extent to sort of, what we can remember. We're not all like Hershers, and so, I think that's always. But that's why when I do teaching cases with my residents, when it has been several days where we don't quite know exactly what the diagnosis is, I always make sure that we kind of circle back and make sure that we've looked at a differential in full and looked at some sort of list to make sure that we've sort of looked at all the exhaustive options and have considered everything. In this case, we sort of did not, but in the future, that's something to remember.
I think the problem with using like Watson in some case like this is there was no specific finding in the initial history and physical. So if you plug those things into like Watson, you're going to get the list you just showed us of the Miami things, and then it's going to say, what's it going to tell you to do? Like test for every single one of those, or get a biopsy, which is what you ended up doing anyway. I don't see how it would have changed the outcome here.
Yeah.
And I just think it's interesting to have the med student like go over the whole list.
Right. And we're like, oh, like right, yeah. And I think, yeah, we hadn't even discussed that, and so I think if we had maybe like done a quick search and been like, oh, this sounds just like her, then maybe that might have raise our eyebrows a little bit sooner. That is a good point.
Well, I think any of those other things also sounded like just like her. Like extrapulmonary sarcoid could have easily been this diagnosis, or like asthma's could have been this diagnosis. Like any of the a lot of the things on that list could have been the diagnosis.
Yeah, so at the end of the day, we just needed a lymph node biopsy. Okay, well, thanks for participating, everybody. I appreciate it.